Hello. I'd like to begin today with a bit of a disclaimer. This is, by far, the most philosophically based talk I have, ever, attempted. And, in that way, I'd go so far as to say that it's somewhat experimental. So, if, at any point in the seminar, you find yourself thinking, what about the impact of X, Y, or Z? She totally overlooked that. I invite you to bring those things up during our discussion period. I make no promises on whether or not I'll have a coherent response today, but those sorts of questions and comments will be very helpful to me as I consider further explorations of this topic. Okay, here we go. Research consistently indicates that both medicine and bioethics are demonstrably impacted by ableism, that is, prejudice and/or discrimination on the basis of disability, and a focus on autonomy as the cardinal ethical principle which supersedes all others. In the CDI seminar, I will explore the concepts of ableism and autonomy, with a view towards delineating potential epistemic connections between the two in the practice of both medicine and bioethics. I will conclude the seminar by considering some ways in which the application of a disability ethics lens, along with a focus on the concept of relational autonomy, could be applied to the practices of medicine and bioethics in order to mitigate the harmful effects of an overemphasis on autonomy within a medical system that is plagued by ableism. Disability scholars Bogard and Dunn define ableism as stereotyping, prejudice, discrimination, and social oppression toward people with disabilities. Just like other forms of discrimination, such as racism or sexism, ableism can operate on interpersonal, internalized, and systemic/structural levels. Honing in on structural ableism, also known as systemic ableism, and its potential impact on access to healthcare for disabled people, Lundberg and Chen define structural ableism as, quote, a system of historical and contemporary policies, institutions, and societal norms and practices that devalue and disadvantage people who are disabled, neurodivergent, chronically ill, mad, and/or living with mental illness, and privilege people who are positioned as able-bodied and able-minded. This system impacts disabled people regardless of whether they identify as disabled and if their disability is visible, and may also affect other populations perceived as deviating from social, cultural, and economic constructs of productivity and normativity. Structural ableism denies disabled communities equitable access to social resources and to disability competent and affirming health services, control over whether their experiences are listened to and believed, autonomy over how their needs are represented and responded to, and justice when they are exposed to harm, discrimination, and violence. End quote. Interestingly, in this definition of structural ableism, Lundberg and Chen emphasize the fact that structural ableism denies disabled people autonomy over how their needs are represented and responded to. Disability scholar Carol Gill likewise asserts that in a society and a medical system where professionals attach words such as radical, extraordinary, and even futile to breathing and feeding supports disabled people use each day, medical professionals and healthcare administrators often decide themselves what people with impairments need and define what constitutes excessive needs. Ableism is thus causally linked to the denial of disabled people's autonomy bound within a healthcare system that is ostensibly predicated on respect for patient autonomy as its cardinal ethical principle. In order to better understand the processes by which the autonomy of disabled people is routinely denied within the healthcare system, notwithstanding its espousal of patient autonomy as its cardinal ethical principle, it is necessary to first consider the ways in which ableism is manifested in both healthcare and health ethics. The manifestations of ableism in healthcare and health ethics are legion. They range from genetic screening to detect potential disabling conditions in fetuses, which will then become candidates for selective abortion, to doctors' offices with examination tables that are inaccessible to wheelchair users, to pandemic triage protocols which list pre-existing disability as an exclusion criterion for receiving critical care in the event that the medical system is overwhelmed to the point that critical care resources need to be rationed. Such manifestations of ableism are rooted in an ableist biomedical understanding of disability as defect and deficit, rather than as a naturally occurring form of human variation. In the words of disability scholar, Fiona Kumari Campbell, ableism is centered on a deficit-based construction of disability that is inherently linked to a biomedicalist stance, which, since the age of reason, has played a critical intervening role in the lives of people with disability and people with anomalous bodies or mentalities. David Mitchell and Sharon Snyder have articulated this predominant ableist biomedical understanding of disability as defect and deficit in their declaration that, quote, disability is the master trope of human disqualification. End quote. I contend that this notion of disability as the master trope of human disqualification is nowhere more clearly seen and more regularly enacted than in the realms of healthcare and bioethics. Furthermore, as I will demonstrate in the next sections of this presentation, it is in and through the veneration of the principle of autonomy in healthcare and bioethics that disability indeed becomes the master trope of human disqualification. A fundamental step in understanding how, exactly, this happens is to examine the concept of autonomy, and its role in bioethics and healthcare. So, what is autonomy? Etymologically, the word autonomy is derived from the ancient Greek words autos, meaning self, and nomos, meaning rule. Thus, most basically defined, autonomy is an individual's capacity for self-determination or self-governance. Plato and Aristotle both associate the ideal for humanity with self-sufficiency and a lack of dependency on others. For Aristotle, self-sufficiency, or autarkia, is an essential ingredient of happiness, and involves a lack of dependence upon external conditions for happiness. The best human will be one who is ruled by reason, and is not dependent upon others for his or her happiness. 18th century philosopher, Immanuel Kant further developed the idea of moral autonomy as having authority over one's actions. Rather than letting the principles by which we make decisions be determined by our political leaders, pastors, or society, Kant called upon the will to determine its guiding principles for itself, thus connecting the idea of self-government to morality. Instead of being obedient to an externally imposed law or religious precept, one should be obedient to one's own self-imposed law. The former he called heteronomy, the latter autonomy. In his What is Enlightenment essay, he described enlightenment as the human being's emergence from his self-incurred minority and called on his readers to have the courage to use their own understanding without direction from another. However, as Dryden points out, quote, between Kant's description of moral autonomy and the recent scholarship on personal autonomy, however, there was a process of individualizing the idea of autonomy. The Romantics, reacting against the emphasis on the universality of reason put forth by the Enlightenment, of which Kant's philosophy was a part, prized particularity and individuality. They highlighted the role of the passions and emotions over reason, and the importance of developing one's own unique self. John Stuart Mill also praised and defended the development and cultivation of individuality as worthwhile in itself, writing that, quote, a person whose desires and impulses are his own, are the expression of his own nature, as it has been developed and modified by his own culture, is said to have a character. One whose desires and impulses are not his own has no character, no more than a steam engine has a character. End quote. From Mill. The Romantic conception of individuality was then echoed within the conception of authenticity that runs through phenomenological and existential philosophy. Heidegger posits an inner call of conscience summoning us away from
das Man.
In order to be authentic, we need to heed this inner call and break away from inauthentically following the crowd. This conception of authenticity became intertwined with the idea of autonomy. Both involve a call to think for oneself and contain a streak of individualism. End quote. From Dryden. In terms of our exploration of the impact of ableism on the bioethical principle of autonomy, it seems to me highly significant that our contemporary definition of autonomy as self-determination and self-governance is clearly linked back to Aristotle's notion that self-sufficiency is an essential ingredient of happiness, and involves a lack of dependence upon external conditions for happiness. This is because, as I will demonstrate, by thus privileging self-sufficiency as essential to autonomy, disabled people for whom dependence on others is essential to survival, are summarily excluded from having both their capacity for autonomy and their means of exercising relational autonomy through things such as shared decision making and facilitated communication go unrecognized in the healthcare system. I'd like to spend the next few minutes considering the role of autonomy in healthcare and bioethics. The field of bioethics was originally conceived of as being based on four fundamental principles: autonomy, justice, beneficence, aka, do good, and non-maleficence, aka, do no harm. Over the course of the last 30 years, however, autonomy has become the cardinal principle of bioethics, the principle that supersedes all others. Beecham and Childress describe personal autonomy in the following terms, quote, "Personal autonomy is, at a minimum, self-rule that is free from both controlling interference by others and from limitations, such as inadequate understanding, that prevent meaningful choice. The autonomous individual acts freely in accordance with a self-chosen plan, analogous to the way an independent government manages its territories and sets its policies. A person of diminished autonomy, by contrast, is in some respect controlled by others or incapable of deliberating or acting on the basis of his or her desires and plans. For example, prisoners and mentally retarded individuals often have diminished autonomy. Mental incapacitation limits the autonomy of the retarded person, whereas coercive institutionalization constrains the autonomy of prisoners. End quote. Besides bristling at the outdated, though not for the early 2000s, and ableist terminology used by Beecham and Childress, the disability ethicist in me is compelled to point out that the developmentally disabled person is very likely to be likewise subject to forced institutionalization, albeit in a long-term care facility rather than a prison. Thus, the illustration presented here is based on a false dichotomy in that it is highly probable the developmentally disabled person faces barriers to exercising autonomy beyond their cognitive impairments. Beecham and Childress go on to assert that the main threats to autonomy, as they conceptualize it, are ignorance and explicit coercion. Thus, to judge whether a person has the opportunity to act autonomously, the bioethicist must simply check to see if he or she has a substantial degree of understanding and freedom from constraint. Of course, in this view of autonomy, constraint or controlling influences are characterized as interference from others with greater power, such as governments or physicians. As Beecham and Childress illustrate, within bioethics, the physician's paternalistic influencing of the patient's choice is the paradigmatic case of such a constraint. Quote, "We encounter many problems of autonomy in medical contexts because of the patient's dependent condition and the medical professional's authoritative position. In these circumstances, the patient's autonomy is sometimes compromised because the physician has assumed an unwanted degree of authority, as in certain paternalistic actions." End quote. In my view, The fundamental problem with the notion of autonomy in medical contexts, as Beecham and Childress conceptualize it, is that, despite the many protestations they make to the contrary, it fails to adequately take into account factors within and beyond the immediate clinical context which could impinge on a patient's, particularly a disabled patient's, ability to make autonomous decisions. Such factors could include no access, or limited access, to one or more of the social determinants of health, an inability to access disability-related supports, such as facilitated communication or equipment to make clinical spaces accessible, and a lack of emotional and/or communication resources needed to combat ableist attitudes among their healthcare providers. Beecham and Childress are far from alone in privileging and promoting a conceptualization of autonomy that ignores the realities of medical and structural ableism, and instead focuses on the Aristotelian notion of self-sufficiency as an essential component, not only for human happiness, but for humanness itself. As Anita Ho observes, within moral and political philosophy, quote, the capacity for rationally determining one's own ends or destiny is the locus and origin of one's unique and unconditional value. End quote. Consequently, autonomy, as a moral and ethical value, has become a cornerstone, not only for medicine and bioethics, but indeed for Western democratic societies. In the words of Charles Foster, autonomy, quote, means that we all have a life plan, we all have a right to have it respected, and if we are to talk about such disreputable, autonomy truncating things as duties at all, we merely have duties not to interfere with others' life plans. Anyone so contemptibly subrational or unreflective as not to have a life plan is hardly human at all. If one can spare a little time in one's own life plan to help the unreflective limp toward higher self-realization, that is a good thing, and the God will be pleased. End quote. Foster goes on to argue that, quote, this is the orthodoxy, and it is policed with terrifying vigor. To depart from it is dangerous, and so the medical ethics journals are full of detailed descriptions of and reflections on the brocade on the emperor's entirely absent clothes. End quote. Foster compellingly points out that, within medical ethics, autonomy has attained the status of infallible orthodoxy. As such, it has indeed become the cardinal ethical principle, to which all other principles and considerations must be subservient. On a practical level, this means that any voices which challenge the supremacy of autonomy as a foundational ethical and moral principle are called into question, if not totally silenced. This undermining and silencing becomes all the more problematic given the fact that such challenges to the supremacy of autonomy often come from disability ethicists and disability rights activists. In the next section of this presentation, we will look more specifically at the ways in which medical ableism problematizes the role of autonomy in healthcare and health ethics. Disability ethicist Joel Michael Reynolds, who, by the way, is going to be the keynote speaker for our upcoming virtual Disability Ethics Symposium on November 21, 2024. Watch for more details coming soon. End of commercial. Reynolds conceptualizes ableism as a conditioning principle in bioethics, that is, a principle that implicitly or explicitly grounds, limits, or otherwise determines the possibility of other principles. That is to say, conditioning principles are determinative of which other principles a person holds as well as the role those principles play relative to one's larger epistemic framework. Central to the function of ableism as a conditioning principle in bioethics is the conjunction of the following four claims, quote, 1. Abilities or capacities are qualities, properties, characteristics, features, or dispositions of individuals. 2. Abilities create, comprise, and or confer value upon the life of an individual. 3. Given, 1. And, 2. Abilities are central to an individual's well-being, fundamental to the meaningfulness of their life, and determinative of their actual and also potential social standing, social roles, and social capital. 4. Disabilities, understood as a lack or deficiency of abilities as understood in 1. Negatively impact one's value, per 2, and well-being, per 3. End quote. Within the epistemic schema that Reynolds articulates here, ableism is the filter through which all presentations of disability in the realm of bioethics are viewed and understood. Significantly, claims 2 through 4 in this schema are implicitly linked to notions of disability as in some way limiting autonomy insofar as abilities and capacities, that is, the absence of disabilities, are conceptualized as being determinative of one's ability to exercise one's autonomy. In other words, disability devalues a person's life by virtue of the fact that it curtails that person's capacity to autonomously shape their own life in terms of pursuing desired social roles and social standing. The epistemic schema of ableism thus dictates that such a curtailment of a person's capacity to autonomously shape their own life is caused solely and completely by that person's disability, without any consideration of the fact that the disabled person is living in a society that is dominated by ableism, and that this likely plays a much larger role in curtailing the disabled person's autonomy than does the person's disability. Integral to the ableist epistemologies which are manifested in healthcare and health ethics, and which impinge on the autonomy of disabled people who enter these realms, is the power differential that exists between healthcare providers and their patients. Ebony Caldwell, a psychiatrist who has an acquired disability, argues that the harms caused by ableism in healthcare are, to a large extent, rooted in this power differential. Quote, one power hierarchy that has resulted in significant harm to the disabled community is that of the physician and patient. Particularly in the field of psychiatry, this hierarchy has served as the poster child of medical paternalism, in which the provider knows best, and the patient has no autonomy. This tiering served as the background of the eugenics movement of the 20th century. Healthcare providers became the perpetrators of acts of violence and discrimination against people with disabilities, including sterilization, institutionalization, and denial of treatment, particularly of women and people of color, all under socially normalized ableist premises. Still today, healthcare operates under the ableist guise that normal is best. Across decades, clinicians have been found to consistently report the quality of life of people with disabilities lower than what individuals self-report. This ableism unduly influences healthcare workers' attitudes and biases towards people with disabilities, resulting in them having poor communication with and even being uncomfortable providing care to the disabled community. Even terms to describe this phenomenon, such as the disability paradox, suggests that to have a disability and live a fulfilling life are at odds. As a result, it becomes simple for medical providers to attribute the numerous health disparities experienced by people with disabilities as unavoidable comorbidities and secondary conditions. Medical education does not provide most clinicians with appropriate skills and knowledge to adequately care for people with disabilities, which both patients and clinicians report. Even though accrediting bodies for both medical school and graduate medical education state the importance of caring for these patients, there is no standardized disability curriculum to ensure adequate delivery of care. End quote. Caldwell delineates numerous ways in which the power differential between healthcare providers and their patients within a healthcare system that is saturated in ableism has denied disabled people their autonomy, resulting in their experiencing serious harms and abuses within the healthcare system. These harms and abuse have included sterilization, institutionalization, and denial of treatment, particularly of women and people of color, all under socially normalized ableist premises. Caldwell then goes on to link these harms and abuses caused by ableism to a fundamental lack of knowledge on the part of clinicians about how to treat disabled people, noting that medical education does not provide most clinicians with appropriate skills and knowledge to adequately care for people with disabilities. Ultimately, therefore, the prevalence of ableism within the healthcare system is perpetuated through inadequate education on disability and disability-related issues in medical school and other disciplines within healthcare. The deleterious effects of such medical ableism are exacerbated by the power differential that exists between clinicians and their disabled patients, oftentimes resulting in the autonomy of disabled patients being undermined and denied in ways that lead to physical, emotional, and psychological harms, and even abuse. Having looked at the many ways in which the prevalence of medical ableism problematizes the privileging of autonomy as a cardinal principle in healthcare and bioethics, I would now like to consider the potential for disability ethics and relational autonomy to function as disruptors of the biomedical and bioethical privileging of a notion of autonomy that is steeped in ableism. Disability ethics is an interdisciplinary approach to examining, analyzing, and reaching decisions about ethical dilemmas regarding life with disability. It addresses many of the same issues that bioethics addresses, and expands the focus beyond medical issues. It includes legal, policy and social justice issues that affect daily living for people with disabilities. Disability ethics shares the central theme of the disability rights movement: nothing about us without us. Consequently, the primary aim of disability ethics is to ensure that the perspectives of people with lived experience of disability are central to discussions and debates about ethical issues involving disability and people with disabilities. In the words of Jackie Leach Scully, quote, "Disability ethics, like feminist ethics, is a form of ethical analysis consciously and conscientiously attentive to the experience of being/having a different embodiment. And doing this means working from people's experience of disability to see if and how it colors their perceptions, interpretations, and judgments of what is going on in moral issues, especially in moral issues that have direct relevance to disability and where differences in the experience of disability might be expected to have weight." End quote. Disability ethics thus functions as an ethical framework which centers the lived experiences and perspectives of disabled people in discussions and debates about ethical issues involving disability. Because, as we have already seen, by and large, disabled people tend to view their own lives very differently than their healthcare providers view them. It is not surprising that the application of a disability ethics framework involves the redefinition of central ethical concepts, like autonomy. The fact is that, viewed through a disability ethics lens, autonomy looks and functions very differently than it does in traditional bioethics. This is because, as Catherine Moore points out, quote, "People with disabilities may experience autonomy and choice, and therefore their sense of self, differently than non-disabled people. It is of unique concern to people whose autonomy is often taken away." Furthermore, the Kantian emphasis on rationality can also be used as a weapon to strip certain individuals of their own autonomy. End quote. For many disabled people, exercising autonomy necessitates some form of dependence on others to help create and or maintain the conditions that make it possible for them to enact a chosen course of action. Ringel argues that, quote, "Professionals tend to define independence in terms of self-care activities. So, independence is measured against skills in relation to performance of these activities." Disabled people, however, define independence as an ability to be in control of and make decisions about one's life. Independence is then not linked to doing things alone or without help, but by obtaining assistance when and how one requires it. End quote. Within a disability ethics framework, therefore, autonomy is redefined from an independent action carried out in isolation, to the facilitated ability, through the assistance of others, to choose a course of action and carry it out. Significantly, this redefinition does not occur by means of a static, one-time process. Rather, it occurs through an iterative evolution from an early emphasis by the independent living movement in the 1970s and 1980s on a more traditional biomedical notion of autonomy as consisting in both independent choice and independent action, to the early 2000s, which saw increased attention to, and, ultimately, the adoption and interpolation of, the feminist concept of relational autonomy into disability ethics. In the 1980s, feminist philosophers began to question the traditional individualistic conception of autonomous agents and the means by which they make moral decisions. A growing recognition of how gender differences privileged certain aspects of moral knowledge led to the development of an ethics of care, which shifted the focus of how we reason about morally difficult choices. This feminist approach was also applied to conceptions of autonomy. These philosophers described a different way of thinking about autonomy that was relational rather than individualistic. As McKinsey and Stolger explain, quote, relational autonomy perspectives are premised on a shared conviction, the conviction that persons are socially embedded and that agents' identities are formed within the context of social relationships and shaped by a complex of intersecting social determinants, such as race, class, gender, and ethnicity. Thus, the focus of relational approaches is to analyze the implications of the intersubjective and social dimensions of selfhood and identity for conceptions of individual autonomy and moral and political agency. End quote. Relational autonomy thus centers on an acknowledgement that, as human beings, we all fundamentally and ineradicably exist in relation to others. It likewise acknowledges that both good and evil result from the fact of our interdependence, but holds that self-realization is only achieved relationally. Like disability ethics, relational autonomy rejects the traditional biomedical privileging of independence over interdependence, contending instead that people do not abdicate their autonomy by asking trusted family members to make decisions for them, or asking their healthcare providers to offer their opinions. An individual's interests are developed in conjunction with others. They are redescribed and re-examined during challenging times. Dialogue with others about these interests and choices is not an affront to an individual's autonomy in this relational model. It is, instead, the only way to allow autonomy to fully flourish. From a disability ethics perspective, relational autonomy helps to promote an emphasis on interdependence over independence, through its focus on the reality that, as human beings, we are all interdependent on one another. Relational autonomy exposes as a fallacy the ubiquitous ableist biomedical construction of an immutable dichotomy between a normal, healthy, able-bodied and able-minded, autonomous us, and an abnormal, sick, disabled, and dependent them. In this way, relational autonomy supports and amplifies the disability ethics critique of the traditional ableist biomedical and bioethical conception of disability as a lack or deficiency of abilities that necessarily negatively impacts both one's well-being and one's ultimate value, in large part by making it impossible to exercise autonomy. As we have seen, both disability ethics and relational autonomy are frameworks of ethical analysis which problematize and disrupt traditional biomedical and bioethical conceptions of autonomy in some interesting and important ways. Within a disability ethics framework, autonomy is redefined from an independent action carried out in isolation, to the facilitated ability, through the assistance of others, to choose a course of action and carry it out. Similarly, Relational autonomy rejects the traditional biomedical privileging of independence over interdependence, contending instead that human flourishing is only achieved in relationship with others. Hence, it seems to me that foregrounding disability ethics and relational approaches to autonomy in clinical settings could be very effective in disrupting ableism in several ways. Firstly, foregrounding these approaches could help to mitigate potential harms caused by the power imbalance between, generally non-disabled, healthcare providers and disabled patients in a healthcare system that is saturated by ableism, insofar as it would recognize as valid the experience and expertise of disabled people who exercise their autonomy through relational means, such as shared decision-making or facilitated communication. Secondly, foregrounding disability ethics and relational approaches to autonomy in clinical settings would necessitate a shift in focus away from a narrow definition of autonomy as necessarily carried out completely independently by a self-governing individual, towards a broader definition of autonomy as, in some sense, a cooperative project that works towards a common good. It is important to recognize that such a decoupling of autonomy from individualism constitutes a major heresy against what Foster calls the orthodoxy of autonomy. Therefore, attempts to broaden the notion of autonomy in this way are often met with strong resistance from those who consider such attempts as threats to respect for autonomy as a cardinal ethical principle. Thirdly and finally, foregrounding these approaches in clinical settings would foster what Eva Kette calls epistemic modesty, that is, knowing what one does not know, among clinicians. However, true epistemic modesty among clinicians necessitates not only knowing what one does not know, but also owning, acknowledging, what one does not know in terms of unrecognized personal ableist biases. Such genuine and transparent epistemic modesty on the part of clinicians would directly and severely challenge long-established, conventional notions of medical professionalism. Hence, the general lack of such genuine and transparent epistemic modesty among clinicians remains one of the most formidable and entrenched barriers to disrupting and dismantling medical and systemic ableism. Before we move to a time of discussion, I'd like to offer just a couple of concluding thoughts on the often harmful impacts of an overemphasis on autonomy within a medical system that is plagued by ableism. For those who have heard me speak before, and who are perhaps excitedly thinking, wow, she's actually going to make it through an entire seminar, without talking about MAID. Yeah, no, sorry, but it's not possible. The reason that it's not possible is because, as Joseph Strimondo points out regarding physician-assisted suicide, PAS, the older, but, in my view, more accurate, term for medical assistance in dying MAID, the conventional, and narrow, bioethical understanding of both autonomy and coercion fails to take into account the impact of the social context of systemic oppression in which such choices are often made. Quote, most mainstream bioethicists perceive the main moral dilemma of PAS as a classic conflict between the principles of beneficence and autonomy, mostly viewing those seeking PAS as vulnerable patients needing to be empowered to express their autonomous choices in defiance of the illegitimate authority of paternalistic physicians. Of course, bioethics does not approach the topic with absolute unity, but much of mainstream bioethics analysis of PAS can be traced directly back to the origins of the field itself and the particular, dominant view of autonomy it has typically endorsed. End quote. Strimondo goes on to explain that, quote, for Beecham and Childress, the main threats to this widely accepted view of autonomy are ignorance and explicit coercion. Thus, to judge whether a person has the opportunity to act autonomously, the bioethicist must simply check to see if he or she has a substantial degree of understanding and freedom from constraint. Of course, In this view of autonomy, constrained or controlling influences are characterized as interference from others with greater power, such as governments or physicians. As Beecham and Childress illustrate, within bioethics, the physician's paternalistic influencing of the patient's choice is the paradigmatic case of such a constraint. We encounter many problems of autonomy in medical contexts, they write, because of the patient's dependent condition and the medical professional's authoritative position. In these circumstances, the patient's autonomy is sometimes compromised because the physician has assumed an unwanted degree of authority, as in certain paternalistic actions. This is the dominant view of how and why autonomy ought to be applied to issues in bioethics generally and PAS in particular. Beecham and Childress are clear that this view of autonomy is the guiding principle for thinking about physician-assisted suicide. Quote, if a person freely authorizes death and makes an autonomous judgment that the cessation of pain and suffering through death constitutes a personal benefit rather than a setback to his or her interests, then active aid in dying at the person's request involves neither harming or wronging. Assisting an autonomous person at his or her request to bring about death is, from this perspective, a way of showing respect for a person's autonomous choices. Similarly, denying the person access to other individuals who are willing and qualified to comply with the request shows a fundamental disrespect for the person's autonomy. End quote from Beecham and Childress. Of course, Beecham and Childress do not unequivocally endorse the legitimacy of every case of PAS, and they concede that PAS must be done in a way that prevents abuse, lack of social control, absence of accountability, and unverifiable circumstances of a patient's death. Yet they have a narrow, if extremely common, view of what constitutes coercion and, thus, a narrow view of the kinds of factors that may limit patient choice. The most important secular social justice argument offered by the disability movement against PAS is aimed at problematizing the sort of simple appeal to autonomy used by mainstream bioethics to support PAS. Many argue that appeals to the autonomy of the individual to choose PAS do not recognize the social context of oppression within which the supposed choice is made and that the conditions of this context compromise the authenticity of the individual's choice by obscuring the coercive impact of systemic, institutionalized discrimination. End quote from Strimondo. I find it both telling and disheartening that, despite the fact that it has now been over 2 decades since Beecham and Childress published Principles of Biomedical Ethics, and almost 8 years since Strimondo published this article, the description of bioethics' narrow view of coercion and its obfuscation of the coercive impact of systemic discrimination remains an accurate articulation of the tensions which endures between the field of bioethics and disability scholars and disability rights activists. Echoing Kitte's notion of epistemic modesty, Strimondo argues that, quote, developing a widespread, rich understanding of the phenomenal experience of disability from a social and political viewpoint, rather than a purely medicalized one, would go a long way toward establishing the conditions in which non-disabled bioethicists and healthcare providers could develop the moral perception and reasoning that would let them enter into constructive dialogue with the disability movement about ethical concepts that are of utmost importance to both communities. End quote. I echo this assertion. If bioethics is ever to effectively treat its congenital ableism, it must consciously and conscientiously move away from its narrow conceptualization of disability as defect and deficit, and develop a more holistic understanding of disability as a form of human variation and a viable way of being in the world. Only in this way can the conventional bioethical notion of autonomy be rehabilitated. Thanks for your attention. My cat, Awkward, and I are sitting by for your questions and comments.